Hello friends, welcome to Cortex YouTube channel. Today in this video I am going to discuss about importance of platelet count in chronic liver disease patient. This is an LFT report of DCLD patient presented to us with upper GI bleed. So this is a case of DCLD. So look at the bilirubin parameters, they are raised, and enzymes pattern you look. So it is AST divided by ALT is more than 3, so it is suggestive of ethanol. This patient was chronic alcoholic and albumin is 1.8, which suggests chronicity, so it is a DCLD ethanol induced. So just by looking at the CBC report of this patient, we can predict whether this patient is having portal hypertension or not. These are the lines exactly taken from the textbooks. A reduced platelet count is the single parameter most consistently associated with portal hypertension of any cause. Underline any cause. Thrombocytopenia, that is less than 150,000 cells per cubic millimeter, strongly suggests portal hypertension in patients with cirrhosis. A lower platelet count, that is less than 100,000 cells per mm cube, is closely associated with the presence of gastroesophageal varices. So this patient had esophageal varices. Let's look at his CBC report. CBC report shows there is moderate normocytic normochromic anemia, and look at the platelet count. It is 48,800 only. So 48,000, which is very much reduced, so less than 100, so it is less than 50. So this suggests there is a portal hypertension, and the book also goes to mention that even if a patient with CLD, in cases of CLD patients or cirrhosis patients, if you find normal platelet count, you have to start working up for hematological abnormalities like myeloproliferative diseases. So that much significant is the platelet count in cases of cirrhosis or chronic liver disease patients. And what are the causes for thrombocytopenia in CLD patients? One thing is because of hypersplenism induced by splenomegaly, and another thing is your reduced thrombopoietin synthesis. These are the two important causes, and it strongly suggests portal hypertension. That you have to remember. That is the take home message 1. And one more important implication of platelet count in cases of CLD is it can predict whether the patient is having advanced fibrosis or cirrhosis. Yeah, before going to that discussion, let's look at this ascitic fluid analysis of this patient. This patient serum albumin was 2.5 and ascitic fluid albumin was 0.4 only. So it is a high SAC, low protein. So look at this, only 0.4. So low protein. High SAG low protein also suggests portal hypertension. So thrombocytopenia and high SAG low protein are suggesting of portal hypertension in this case. Yeah, let's look at whether it predicts your advanced fibrosis or cirrhosis in this case or not. So for that we have to use various non-invasive tests or formulas. One important formula or non-invasive test is APRI. That is your AST to platelet ratio. AST to platelet ratio. So how to calculate APRI? You have to take AST, patient's AST, I'll write P here in bracket, divided by upper limit of normal AST whole divided by platelet count 10 to the power of 9 per liter into 100. So in this case, if you calculate, AST is 101 and normal is 441, platelet count is 48 into 10 to the power of 48.8 into 10 to the power of 9 per liter into 100. If you calculate this, you will come across a number 5, so which is more than 1.5. So this here APRI suggests of predicts cirrhosis. In this case it is cirrhosis. So I'll give reference for this APRI cutoff value. This is exactly from taken from Harrison. Look at this APRI AST platelet count. If it is more than 1, you can say it is advanced fibrosis. If it is more than 1.5, range is 1 to 2, more than 1.5, you can say it is cirrhosis. And there are other non-invasive tests which I will be discussing in coming video. Stay tuned, follow for more such videos. If you like this video, please share and subscribe, and share among your friends and juniors, colleagues. Okay, thank you.